اي فندم، ازي حضرتك؟
ازيك؟ وحشنا مبارك.
حضرتك
ده بقى
أكتر.
فعلا مسك الختام بتاع النهارده. طبعا it's my great pleasure to introduce Professor Muhammad Salahuddin, the well-known Professor Muhammad Salahuddin. And طبعا احنا مشكلة ال patients اللي هم بيبقوا sensitized ومش عارفين يزرعوا. You know how miserable these patients become, and now he is going to be speaking about desensitization, National Institute of Urology and Nephrology experience, and we are all eager to hear this experience. Professor Muhammad Salah, please go on.
اولا شكرا جدا لحضرتك، وانا كنت بقول لهم يسيبوا حضرتك تتكلمي، انا كنت مستمتع الحقيقه بالمحاضره. مش مشكله المحاضره بتاعتي خالص، لان الموضوع اللي حضرتك كنت بتتكلمي فيه كان موضوع فعلا يعني مهم قوي، واحنا بنستمتع بمحاضرات حضرتك دايما. الحقيقه برضو it was a very short notice من روش اللي انا بحب اشكرها قوي على اتاحه الفرصه. فالاكسبيرينس بتاعتنا في معهد الكلى I will go through it بسرعه، لكن هتكلم على desensitization. As you all know, I'm the chairman of nephrology and internal medicine departments في National Kidney Institute, or the National Institute of Urology and Nephrology. This is the pictures from the National Institute, and and unless the corona pandemic next year إن شاء الله والدنيا تتحسن ونرجع
الصوت بيقطع والله، الصوت بطيء شوية.
الصوت بيقطع. الصوت اخباره ايه؟ الو؟
ايوه دلوقتي كويس.
يا النهارده مش عارف يعني. كده طب ايه، معقول احسن ولا؟
كده كويس، كده كويس كان.
historical background عن معهد الكلى القومي. it was founded 1995 بقرار رئاسي، وبدأ العمل فعليا بمسماه الجديد سنة 96. والفيرست successful kidney transplant في المعهد was in 1986 قبل ما يتحول لمعهد الكلى، لما كان لسه قسم الكلى والمسالك في مستشفى المطرية التعليمي. طبعا الفاوندر والجود فاذر بتاع المعهد هو المرحوم استاذ الدكتور ابراهيم ابو الفتوح رحمه الله عليه. حتى الان we performed 1030 حاله، اخر حاله كانت الاسبوع اللي فات. و the number of desensitized patients over the last 5 years اللي اتعمل لهم desensitization كانوا 30 patient. all of them were successfully desensitized and transplanted and followed up to now with good graft function. المعهد عندنا في 96 machines. We perform around 8,000 dialysis sessions per month. دي صورة دكتور إبراهيم أبو الفتوح الله يرحمه. introduction بقى عن
الصوت وقف.
صوت انا كده وحش. Kidney transplantation is the treatment of choice for patients with end-stage kidney disease, as we all know, in terms of survival and quality of life. Human leukocytic antigen sensitization is a significant barrier to successful kidney transplants, and it often translates into difficult cross-matches before transplant and increased risk of acute and chronic antibody-mediated rejection after transplantation. Over the last decade, several immunomodulatory therapeutic pathways have been emerged, allowing for increased access to kidney transplants. And we all found that the patients did the desensitization and passed to transplantation had a better survival graft even than those who are not transplanted, even with the risk, increased risk of having problems post-transplant, yet the survival and the quality of life was much better than being on dialysis. HLA sensitization, and I will go through the slides very rapidly because of the time. I know we are very late. HLA sensitization results from exposure to alloantigens. As in previous pregnancies in multiparous, half of the fetus genes are allogenic, and so are many of the cellular antigens. The mother's immune system tolerates the fetal tissue growing in the uterus, but can simultaneously mount a humoral and cellular immune response against paternal antigens, including the HLA, which is a paradox not fully understood up till now. Blood product transfusion is another cause, and previous solid organ transplants, which actually, that's why we live now in the era of sensitization. Due to the repeated transplants, most of us were encountered with second kidney transplants and even fourth kidney transplants. We performed one case at the National Institute. It was the fourth, it was transplanted for the fourth time. We have more than 20 cases with third transplants, and second transplants are much more than this. The cases who were transplanted 10, 20, and 30 years ago are starting now to present with failing grafts, and they want to retransplant, and that's why we are encountered more and more with the sensitized patients. The match, as we all know, the HLA typing identifies the alleles carried by a person. Matching compares donors' alleles to recipient alleles. Degrees of HLA matching at A, B, and DR loci affects the survival of the allograft. This is quickly the HLA class 1 protein expressed on all nucleated cells, and it recruits cytotoxic lymphocytes CD8, while class 2 expressed only on antigen-presenting cells, macrophages, dendritic cells, and B cells, and recruits the T helper CD4 cells. Prevalence of HLA sensitization in kidney transplant candidates, as we can see here, is growing rapidly day by day, year by year, and now it's even more. This was a study in 2010, but now I think the number is much more than this. As we mentioned before, the grafts that are failing and returning back seeking for retransplant. The PRA, as we all know, it determines if someone is high immunologic risk or sensitized. PRA above 30 usually is considered high. Highly sensitized patients, it is different from country to country, where the potential recipients of a graft with an amount of circulating anti-HLA antibodies that limits the access to transplantation. In Spain, they consider PRA by CDC more than 90 to be high. Eurotransplant considers PRA by CDC more than 85%. In the UNOS, in the United States, United Network of Organ Sharing, the PRA above 80 is considered high. Calculated PRA represents the proportion of the population to which the person being tested will react via pre-existing antibodies. So we have low risk below 10, moderate 10 to 25, and above 25 is usually considered a high risk. Calculated PRA is a quantitative measure expressed as percentage of the proportion or the portion of the general population for which a candidate recipient has circulating antibodies. Higher calculated PRA reflects increased difficulty in finding a suitable donor. It's not a new issue, by the way. It's an old one back to 1969, where the first time they expressed or described the problem of an existing cytotoxic antibodies against donors were detected, and it was published in the New England Journal of Medicine in 1969. Detection, we all know there are many ways. I will just go through the names. The flow, PRA, These are other ways, membrane-based peripheral leukocytes or cell-linked complement dependent cytotoxicity or CDC, and solid phase ELISA or fluorescent-based assays, Luminex and flow PRA, which have better specificity and quantification than the CDC. This is an approach for the anti-HLA antibody detection techniques for solid organ transplantation. As we mentioned, the CDC, the flow, and the ELISA techniques. Flow cross-match, quantitation, its channel shifts intensity of fluorescein above control, a number of dilutions required to generate a negative result. That's the idea of the test. Luminex test, it's better because it's removal. It works on removal of false positives because of antibody binding to non-HLA antigens. Antigens present can be controlled, so confusion regarding the class of HLA they are binding to is eliminated, and positive results graded weak, moderate, or strong based on the degree of fluorescein of the positive bead. Quantitating antibodies, flow cytometry, and the Luminex single antigen bead assay. These can be shown here and shows how we can interpret these tests. Again, this is the classification of antibodies using single antigen reagents and MFI values. We can see that high values or high risk considered above 8,500 MFI, between 2,000 to 4,500, low risk between 1,000 to 2,000, and very weak between 500 to below 1,000. This is a very weak risk. Virtual cross-match is prospective cross-match has been the standard tool for assessing graft recipient compatibility for sensitized patients awaiting cardiac transplantation. Now it has been implemented largely in the nephrology field. It allows assessment of donor, heart, and kidneys as well that might be in risk for exposure to recipient circulating cytotoxic antibodies. The idea of desensitization, which is better to be mentioned as immunomodulation, the term is more right if you said immune modulation. It emerged in the 1990s, the late 1990s, to overcome this hurdle of the human ability to optimize the availability of compatible or acceptable donors, and the development of novel immunomodulatory therapies in the last decade has allowed for refinement of desensitization protocols. This emerged in conjunction with better risk stratification with sensitization, sensitive DSA screening assays, and has led to improved transplantation rates and favorable short and long-term outcomes in these high immunological risk patients. This is an important advancement since end-stage renal disease patients, as we mentioned, are doing much better on transplant rather on dialysis. This is the approach to sensitized patients. Most of the techniques, as you will see, all the techniques will depend on desensitization by the different mechanisms that we will go through, depending on the diagnosis first by CDC, flow cytometry, and virtual cross-matching, and then using the available tools that we will go through quickly now. So if you check the PRA and you have a sensitized patient with PRA below 10%, recheck after 6 months and 2 weeks post sensitizing events, whether infection or transplantation. And if it's more than 10, then you should specify and quantify by doing the Luminex to see the MFIs, and to do prospective virtual cross-matching and calculated PRA, and to perform desensitization if the calculated PRA is above 50%. The basic concepts in desensitization: removal of existing antibodies by plasmapheresis or immune absorption, inhibition of residual antibody and complement cascade by intravenous immunoglobulin, eculizumab, which is C5 inhibitor, depletion of antibody-producing cells, naive and memory B cells, rituximab and obinutuzumab, or plasma cells by bortezomib, and suppression of the T cell response by induction agents, triple immunosuppression with CNIs, MMF, and steroids. Strategies, as we mentioned here, techniques by plasma exchange or immune adsorption, techniques to block antibodies, IVIG, others, rituximab, bortezomib, eculizumab, and obinutuzumab. These are the strategies done for desensitization for living donors, whether to use high-dose IV immunoglobulins or use plasma exchange, immune adsorption, and low-dose IVIG, or plasma change or immune adsorption plus low-dose IVIG, or to combine them with rituximab. These are the protocols. Rituximab and IVIG and then transplant, or plasma exchange and then transplant, or IVIG and then transplant, or combine all the three of them together, which is the standard of treatment that most of the centers use. Maybe the IVIG is not very popular nowadays. Most of the centers rely on the plasma exchange plus or minus 2 doses of rituximab after the finish of the plasma exchange sessions, 5 to 7 sessions, maybe more in some cases, or maybe 8 and sometimes up to 10, and then another dose 2 weeks after, and then recheck after 1 month. And that's actually the protocol that we implement up to now in the National Institute of Urology and Nephrology. In some very limited number of cases, IVIG was tried, but with no superiority in the results versus the rituximab and plasma exchange. This is how the IVIG works, and other antigens, specifically which kind of cells they work on. Rituximab, of course, is very confined to the B cells. So the therapeutic modalities, as we said, plasma exchange, 1.5 volume exchanges, sometimes or some centers use only 1 volume exchange, 5 consecutive days, and then alternating after that. Intravenous IVIG, divided doses over 2 days. Some other use rituximab, as we said, 375 milligram per square meter to be given in 2 doses. Cyclophosphamide also, but it's not very popular. This is a quick, definition or explanation of the mechanisms of the plasmapheresis. Rapid reduction of anti-HLA or isoagglutinin antibodies induces donor-specific unresponsiveness HLA or accommodation by ABO incompatible transplantation. Advantages: it is predictable. Kinetics of plasmapheresis, no evidence of non-responders, able to easily follow DSA levels during and after therapy, or PRA levels during and after therapy. Disadvantages: PRA or DSA may rebound between treatments, or treatment may be prolonged and immunosuppressive. The treatment itself is immunosuppressive, so your patient is in danger of infection, and it's expensive and resource intensively exhausted. This is how the diagram showing the mechanisms of plasma exchange. IVIG, as we mentioned, works on different levels, in almost every single level in the cascade of immune response is affected by IVIG, by blockage of the receptors. Of course, traditional paired kidney exchange is one of the methods to overcome the problem of sensitization, where you can shift one couple, the donor in one couple, to another one who is not sensitized against, and the other one to be exchanged with him to the other couple the other patient who is not sensitized to this unrelated donor. So they are basically 2 couples, related couples, and everyone is donating to the other one because they are sensitized to their own spouse. These are therapeutic approaches agents for immune modulation in HLA sensitized patients, intravenous immunoglobulin, rituximab, pertuzumab, interleukin-6 receptor agonist, IgG endopeptidase, obinutuzumab, anti-B-cell activating factor, C5 inhibitor, eculizumab, C1 esterase inhibitor, and belatacept. And these are the mechanisms of actions of the different agents. We will go through it very rapidly. The tocilizumab, it's a humanized monoclonal antibody, binds to membrane-bound and soluble forms of interleukin-6 receptors and blocks the interleukin-6 binding to interleukin-6 receptor and dissociates interleukin-6 receptor complex. The use of interleukin-6 receptor blockade in desensitization, there is a very interesting studies about this and showing that tocilizumab, anti-interleukin-6, was used in difficult in patients who were to sensitized patients, and it was used showing some promising results. Those patients, 10 out of the patients in this study achieve a DSA reduction sufficient for transplantation after tocilizumab, yet there was some limitations, especially in the infection and so forth. But still, this is a good hope for patients who are sensitized and they were difficult to be desensitized by the traditional methods, and tocilizumab may offer a good benefit in improving rates of transplantation for highly sensitized patients. Obinutuzumab is a humanized type 2 anti-CD20 approved for combination treatment of CLL and follicular lymphoma. It enhanced B-cell depletion versus rituximab, glycoengineering up to 100 times antibody depletion, cytotoxicity, and type 2 binding confirmation, greater direct cell death, reduced internalization, lower complement-dependent cytotoxicity, and greater B-cell depletion than rituximab in tissues and SLE patient samples, and superior to rituximab in H2H trials in B-cell malignancies. B-cell depletion here, if you can see, the diagram is much higher with the obinutuzumab. After only 2 weeks, the patient showed 100% depletion, almost 100% depletion of B cells, and the patient receives again another dose at 4 weeks, 12 weeks, 24 weeks, and the response was almost sustained for around 1 year versus the placebo group. And this, the obinutuzumab was combined with MMF in both cases. So you can see how marvelous is the response regarding B-cell depletion with obinutuzumab. This is also showing that all the B-cell subsets, whether the memory B-cells, the naive B-cells, and plasmablast, they were all showing almost the same response and the same depletion percentage as all of the other in the original study. So it is very powerful B-cell depleting agent on all the B-cells subsets. This study, which is still a phase 1 trial, and it is showing that the safety and pharmacokinetics and pharmacodynamics activity of obinutuzumab in desensitized candidates showed that patients who received 1 day or 2 days infusions of 1,000 milligram obinutuzumab followed by 2 doses of IVIG on day 22 and 43 showed that 11 patients out of the entire number of enrolled patients in the study again received additional obinutuzumab doses at the times of transplant and or at week 24. The median follow-up duration was 9.4 months. Obinutuzumab was well tolerated, and most adverse events were grade 1 to 2 in severity. They were not that intense, and there were 11 serious adverse events in 9 patients, which were around 36%. 10 of these serious adverse events, 10% of these serious adverse events were infection. 10 patients, were infections, and 4 occurred after kidney transplant. Obinutuzumab plus IVIG resulted in profound peripheral B-cell depletion and appeared to reduce B-cells in retroperitoneal lymph nodes. So we can see from this that the obinutuzumab is offering a very good hope for all of us in regarding the desensitization techniques in the future. Is completed, I think that it will be a standard of care in the next decades. Thank you so much, and thank you for having me with you, and thank you for Rush for inviting me for this.
Thank you, Professor Mohammed Salah. Very updated and very comprehensive. Now, let me ask you about your protocol. You mentioned you do plasma exchanges, and then you give 2 doses of rituximab. So we know that the number of plasma exchanges is not really a fixed thing. So how do you tell that I'm going to stop at this point, and when do you say I'm going to transplant my patients? What do you follow?
As you mentioned, Professor May, there is no number that you can say that that's the number that we will all follow. But actually, what we do is we start with 5 consecutive plasma exchanges, as much as there is no contraindication to continue changes as the platelet counts and so forth. And when the patient reaches these 5 exchanges without complications, we continue for another 2 or 3 plasma exchanges every other day, and then we stop at this point. Why we chose this number in particular? Actually, in the literature, most of the centers implemented, and by experience, by developing the experience in the National Kidney Institute, we started with lower numbers before. We started in some patients on higher numbers, and we measured the PRA after completion of the treatment in all of these, and we found that there is no so much improvement when you go for more, and not even and of course the lower number of exchanges were not very efficient when we checked the PRA. Of course, some of the patients we were checking the PRA more frequent, but due to the high expenses, we cannot do it that much. I mean, we cannot repeat it after, let's say, first 5 exchanges, and then we see if the PRA was reduced or not. Besides, there is a redistribution and rebound rate which is high. So if you just test it immediately after session, you might much more less than what's expected than when you go back to the when you recheck after let's say 2 weeks or 1 month from the last exchange. So that's a consensus we reached by time, and which is compatible with the literature, where most of the centers implement the number to be between 5 and 8 sessions.
So after the last session, you measure the PR and you do the MFI after the 8 sessions, after you complete your sessions?
No, not immediately, because of the rebound. Usually, you should wait for a couple of weeks to recheck, or 1 month sometimes recommended to recheck the number. But I mean, if you want to test how good are you in removal You can do it more frequent during the sessions,
Yes,
but
which is
you
not
should
feasible,
expect,
of course.
yes.
So, but you do it before transplanting the patient. When do you say, I'm going to transplant my patient now?
Yes, when you reach a cutoff, a reasonable cutoff, as we mentioned, below 50% PRA is fine, especially if you have a donor who is not in the within the loci that the patient is sensitized against.
Yes, yes. There is also the suggestion that you don't need to desensitize the patient if he's a cross-match negative and his donors doesn't have these loci. So I don't
Yes,
know what you think of that.
this is very true. Actually, I had a case last month, and I was discussing it with my professor, Dr. Gamal Saadi. It was a case exactly as you mentioned, Professor May, a case with a patient who had a high PRA, but yet the donor of the patient has none of the loci that the recipient is sensitized against, not in the A or B or DR or CW or DQ. All the matching, the tissue typing of the donor was completely not sensitized against, the patient was not sensitized against it. And though the patient had a high PRA, which was like almost 60 or 70 percent, yet the recipient has no loci against the donor. So I was confused, and I went through literature. It was not very satisfactory. I spoke with Dr. Gamal, and Dr. Gamal told me that what he do, usually in this case, that he give the patient two or three maximum plasma exchanges in the every other day in the last 4 or 5 days prior to the transplant, and of course to have a negative cross match by CBC and by flow cytometry, and then transplant the patient. And keep in mind that if there is any rise that might happen post transplant, and there is any doubt about that this could be rejection, you can do another plasma exchanges. Actually, if we talk from the very theoretical point of view, if you have no loci against the donor, then you can transplant, and the cross matches are negative, you can transplant safely. But what concerns most of us is that sometimes sometimes there is some problems that might happen with the and you cannot guarantee the lab 100%. You might have a locus that is not present in the assay, so this could be a hazard. Sometimes also the epitopes that can be might not be tested. So it's just kind of we were being more cautious, more royal than the king performing this.
Okay, you mentioned that all your sensitized patients were transplanted. Did you mention that?
All the desensitized patients.
Desensitized patients were transplanted.
Desensitized. Yeah. Due to some limitations, maybe in resources, some limitations in other things. Some went somewhere else. But the patients who performed, the 30 patients who performed the desensitization in the National Institute were transplanted, and they are being followed up till now, and they are doing well. And next time, inshallah, when we will put the results in more details. As I said, it was a very short notice to do the graphs, but I will, inshallah, I will prepare it for any other opportunity, inshallah.
Thank you very much, Professor Mohammed, and I apologize to you all for keeping you late, but that's what happened. But it was really very interesting. Thank you very much.